Good morning. My name is Lori Mahalik-Levin, and as I guess Philip was also not on the mic, but as Philip just said, I do healthcare regulatory policy work here at the ONC. And I want to tell you a little bit about the lens through which I look at the healthcare world, just so you know where I am coming from. And then I believe Philip invited me here so that I could give you a little bit of the bigger picture policy context around meaningful use and how you all may decide that you want to interact with that process or influence that process going forward. So as I said, I'm a regulatory policy attorney, and what that means is you've got Congress, right, which passes a law. And the example I give to my non-healthcare friends is Congress passes a law that says the sky has to be blue. Well, the sky just doesn't turn blue. So the agencies have to go and say what color blue, what kind of paintbrushes are people supposed to use, what's the palette, that sort of thing. And so in this particular world, we're talking about Congress passing a statute called ARA, the American Recovery and Reinvestment Act, and then that gave tons of money to implement electronic health records, but then somebody has to go actually implement those regulations. And so in this case, it's the Centers for Medicare and Medicaid Services and the ONC, the Office of the National Coordinator for Health Information Technology. And so what some people don't know is that the agencies are required to go through a regulatory rulemaking process by law, right? They can't just issue a reg and say, here it is, everybody, you have to follow it immediately. They have to give the public an opportunity to comment on and to provide input on whatever they're doing. So yeah, here on this slide, I've got the statute that we are dealing with here under meaningful use, which is the American Recovery and Reinvestment Act of 2009. It implemented Medicare and Medicaid incentives and penalties, and so that's why you're dealing with CMS here, the Centers for Medicare and Medicaid Services, as opposed to some other component within HHS. And the Office of the National Coordinator for Health Information Technology, which regulates what a certified electronic health record is, was a new entity that was created whenever ARA was passed by Congress. In order to get incentive payments or to avoid penalties under this program, you have to be using a, quote, certified electronic health record, and you have to meet the requirements of the definition of meaningful use applicable at the required time. And so there are separate regulations that come out from CMS versus ONC, and there are separate rules that come out for hospitals versus eligible professionals. And eligible professionals here is broader than just physicians. It's nurse practitioners and some of the other members of the care team. So once you have the statutes, then you've got the regs that need to be implemented. And as I was saying, there is a regulatory rulemaking comment letter writing process. And what happens is the government issues a regulation. Usually they put it online in an advanced double-spaced, big, nice copy that you can print out and read without hurting your eyes. And then a few days later, it will come out in the Federal Register in tiny, tiny print. And so we usually try to read the first version, although it usually comes out to be, a couple thousand pages of print. And then typically the public has 60 days to comment on the regulation that came out from the government. And so folks in, for example, the AAMC's policy shop are furiously reading the reg, telling all of our members what's in the reg and trying to determine what academic medicine's reaction should be to the regulation, and then writing a comment letter, which is not Dear CMS, Love Lori. It's like a 50-page brief on, like legal brief on, what we believe should be in the regulation versus out of the regulation. So by the deadline, the comment letter deadline, we submit this paper to either ONC or CMS, and then they have an opportunity to read everything. They are required by law to read all of the comments that come in, and they're required to reflect in the final rule the fact that they have actually responded to every single relevant comment that has come in. And so then months later, you'll have a final rule. For some regulations, there's a deadline on when the final rule comes out. Meaningful use world, there's no deadline on any of this. CMS and ONC basically came up with the concept of different stages of meaningful use. So stage 1, stage 2, stage 3. There might be a stage 4, 5, 6, 7, and 8, although CMS says that they're just going to stop calling it stages at this point and just call it meaningful use. So we've got CMS, which issues all the payment regulations, how the hospital, how the eligible professional is going to be paid under the Medicare program for meaningful use. And then you've got the Office of the National Coordinator coming out with all the certification regulations, and the focus there is on the standards for the electronic health records. They often, but not always, come out in tandem. When you're advancing the stage of meaningful use, often you'll see another certification rule come out, but we've seen certification rules come out at a time when it hasn't necessarily been tied to each individual stage of meaningful use. So I started talking about how the rulemaking process works. In this specific instance, there are two federal advisory committees, FACA committees, that advise CMS and ONC on what should actually go into these regulations. You have a standards committee and a policy committee. You've got these proposed rules, the 60-day window, the final rule, and as I said, there are no deadlines to issue that final rule. So this year, we arrived at the glimmer in someone's eye of what meaningful use stage 3 should look like. It's not going to go into effect immediately. What they proposed was that stage 3 will be optional in 2017 and required in 2018. But we saw 3 regs come out just over the past couple of months. We saw CMS modify the 2015 to 2017, there's a rule called the 2015 to 2017 modifications rule, which changes some things about stage 1 and stage 2 of meaningful use. There's a proposed stage 3 rule, so showing where you want to go. And then there was a 2015 edition health IT rule, and this is kind of where the standards are. And it basically says that in order for you to be a meaningful use stage 3 user, you have to meet these 2015 standards. I just put this chart up to show kind of how complicated the payment year versus meaningful use stage is. So at your particular institution, when you first dove into meaningful use will determine what year and what stage you are on for meaningful use at a given time. And CMS modified a whole bunch of this to try to line people up all on stage 2 this year. And so the crossouts are all the different changes they made through the various regulations this year. So probably what all of you are most concerned about at this particular moment is the 2015 edition health IT rule, where they did address health disparities and, as I'm sure you all know, included some options for social, psychological, and behavioral data collection. ONC sought feedback on that through the comment letter process, and the AAMC did file a comment letter just a couple of weeks ago. The AAMC, with input from probably all of you and some member feedback, applauded ONC's proposal to include certification requirements for the social, psychological, and behavioral data, and encouraged rigorous patient and community engagement regarding this data collection on a going forward basis. The AAMC offered to partner with the ONC moving forward in the comment letter. So at the end it said, you know, we really look forward to working with you on this. And I believe that there is a lot of opportunity for AAMC through our policy shop here to get involved on this issue should the community be pushing for it and should you want to be partnering on getting involved as ONC moves forward. So really the next steps here are to wait for the final rule to come out. An agency is typically not permitted to talk to the public during the rulemaking process. And I mean, it's not a strict rule in the sense that you can go in there and chat with them, but it consists of you talking and them sitting. So they can listen to you, but they're really not permitted to speak until they issue that final rule. So I have no prediction as to when the final rule will be out. I'd say at the earliest this fall, but as I said, there's no statutory deadline or requirement for when they have to finalize stage 3 or the certification rule, and so one day we will see it, I suppose. There were a lot of folks in the broader community who pushed back on the concept of finalizing stage 3 this year, AAMC included, because there are some quality reporting programs that we're encouraging CMS to align. For example, the SGR package had this new MIPS program for physician payment, and they're saying, they said in the statute that the MIPS program should be aligned with the EHR meaningful use program. So our thought is, well, why, for example, finalize a new set of meaningful use rules if you're ultimately charged with aligning all these quality programs? So why go to a new standard then have to go to yet another new standard? I don't know whether CMS will take any of these comments or push back into account. I suspect they will finalize stage 3 of meaningful use regardless. I know Philip had asked me, so, what's the chance that something that's put in as an option in the standards certification rule, like social behavioral health determinants, will become required under meaningful use? And I mean, my first response was, well, it can't be required unless it's first required to be an option in the health record, in the electronic health record. So I'd say the fact that ONC has proposed to have it as a requirement of the health record is kind of the first step down the path. And then if there is a push by the broader community to get it to be a requirement of meaningful use in order for people to get their money or to avoid payment penalties, then that could come down the line. So I don't know if any of this was helpful, if you already knew all of this, but I'm happy to talk through it, ask questions, answer questions.
Hi, Lori. Samantha Morton from Medical Legal Partnership in Boston, and I apologize if I'm messing up any of my technology.
I can.
To answer your closing question, I found this incredibly helpful because, as your remarks in the slide illustrate, these are incredibly complex interrelationships between relatively more newly organized agencies as well as regulatory processes that are going to have a huge impact. My question for you, I may not be able to answer, is are you aware of what the agency has, either such as in the form of a full-time or a part-time staff member who is focused on their role vis-a-vis health equity and health disparity?
I do not personally know that, but that's definitely knowable. And so I suspect that somebody here at the AAMC could easily figure that out. And, a tool through his policy shop would easily be able to call us folks and figure that out and figure out who the best person is for a meeting, really.
Great. And the reason I ask is just because, for example, clearly the AAMC has prioritized and other associations and agencies are prioritizing that kind of investment in infrastructure and knowledge in-house. It sounds like is open to external feedback on these issues, but it would be very interesting to know whether they're on a path to something internal. Thank you.
Absolutely. And I was speaking with Philip earlier and saying that if this is something I can't tell if this mic is on or not.
Yeah.
Okay. I was telling Philip that if this is something that you all as a group organize around or some community within AAMC organizes around, then there's absolutely no reason why AAMC can't facilitate a meeting with ONC. And actually, I would recommend doing that. Yes, they're required to read your comment letter, but for all the times I've written an agency comment letter, which is many since I've gotten here 6 years ago, and for every time I say, please, the AAMC would love to partner with you on X issue, I haven't heard my phone ring. You have to call them.
Thank you, Lori. I have a question.
Yeah.
So are there, kind of in the step-by-step, ONC releases something, CMS releases something, kind of back and forth. During the meaningful use stage 1 and stage 2 process, have there been examples where something's been included in the final regs on the certification side that has not made it yet in any way, shape, or form into kind of the CMS reporting requirements? I'm not going to hold your feet to the fire around probability that someday our institutions will have to report some of these data. But I'm just curious as to how that usually works.
Yeah, I think that's a fantastic question. I'm going to out myself here as not the certification rule reader. We've had other colleagues and staff who have been on the certification side. I've been on the Medicare payment side. And so, again, a knowable question, and I would recommend maybe chatting with Ethan Kendrick in Health Care Affairs, who was the reader of this year's certification rule. Unfortunately, the person who read the prior certification rules is no longer here at ONC, but an excellent question to look into and maybe find examples of things that have gone one way or the other into meaningful use or not at all. Yeah, I apologize for not knowing that one. I used to go to some of the standards committee and policy committee meetings, and the policy ones I could follow, the standards committee ones were definitely over my head.
Lori, thanks for your presentation. Can you speak to how ONC evaluates meaningful use? Yeah, how do they evaluate organizations who are involved in this?
Right. So it's actually not ONC who's evaluating meaningful use. I suppose it's CMS, the Centers for Medicare and Medicaid Services. So they come up with criteria, measures, that you're required to meet in order to be a meaningful user. In the past, you've had menu and core options. So you've had to meet all of the core options and, 3 out of 5 menu measures in all different domains, from e-prescribing to patient engagement to, do notices pop up whenever physicians are being reminded, physician order entry, all different things. In fact, dozens and dozens of measures. And so CMS will pay you your money, or at a certain point in the program, the money runs out and it all starts turning into penalties. But you will become a meaningful user if you follow CMS's rules for meeting the number of measures and standards and requirements that you were supposed to. ONC only determines if you have a certified electronic health record. And CMS says, in order to get in the door to even start talking about whether or not you've met the required measures for the payment, you have to have a certified electronic health record that's certified under the standards that ONC puts out. Does that help?
Lori, how many of our engaged member institutions have the certified electronic health records?
Yeah, our AAMC members do really, really well under the Meaningful Use program, which is in part why we as AAMC have scaled back our overall involvement in the program and left it to, say, American Hospital Association or whatnot, where they've got a lot more rural institutions and whatnot who are having trouble with the program. But a vast majority of AAMC member hospitals are meaningful users and have met stage 1 and stage 2 of meaningful use.
So I'm guessing that probably every institution here has met that. So where is the discussion then on the activities around avoiding financial penalties or accruing financial incentives? How is that playing out across the institutions that have the certified electronic health record?
The folks who have the certified electronic health record are becoming meaningful users because they want to in order to get the payments and avoid the penalties. And so, I mean, as a general principle, our AAMC member institutions have been getting the payments for the past couple of years.
So I guess my question is, how are they equipped or resourced to, if these optional SBD are part of it, are we hearing how they're resourced to begin to include those?
Well, so if this level of ONC certification, if this gets finalized, then our members would be required to have this level of certified electronic health record for meaningful use stage 3. So that means that they would have to get there by 2017 to 2018. So this is all brand new in the certification world. It's a new rule that just came out a couple of months ago, and so you would see the vendor community, if this got finalized, having to prepare for getting to 2017, 2018, and then they'd be going to all of our members saying, you're going to need to upgrade this to meet the new requirements for 2017, 2018, and then there would need to be people at our institution who would work with the vendors to upgrade the technology, if that makes sense.
Yeah.
I don't know if you can answer this one. Can you hear me? Okay.
I can hear you.
Have anyone looking at this, how meaningful has been meaningful use?
That's an excellent question. lot of opinions on the subject. I think it's been wildly successful in promoting practitioners and hospitals to use electronic health records. There is skepticism as to whether that has actually led to better health outcomes for patients. And I believe that lots of research is being done in that space right now. I mean, it's been an ongoing question from the beginning about whether you are harming or helping through the advancements of technology. So I think it's an open question, a good one to ask. I mean, my personal opinion is that there have been great benefits, but at a lot of cost, right? You're getting a lot of incentive payment from the government, but you're also putting in a lot of your own money and person power and dealing with issues that you problems you were previously not encountering, right?
So, Lori, though, it strikes me that if the social, psychological, and behavioral data are not included, the distinct possibility exists that the use of the electronic health record might widen disparities rather than narrowing the gap. I mean, it seems to me that it would just do that almost de novo.
Mm-hmm. I mean, it's actually a really great thing that this was included in the ONC side, right? I mean, if something's in the proposed rule, it's more likely to be finalized than if it doesn't make its way in there at all, right? So it's a good sign that it was in there. And, I mean, it takes a fairly large community pushback to get ONC to change its mind, ONC, CMS, whatever government agency, to change its mind on something. And so, to me, the fact that they put it in there is an indication that they want to move forward with requiring it in the electronic health record in its certified form. So, I mean, to me, that's a good sign that they're moving in that direction. I think it would require an additional push by a community to get it into the meaningful use requirement so that it becomes required as opposed to just purely optional.
Hi, thank you for your presentation. Yes. I'm Jo Brown from FSU College of Medicine, and I appreciate your comments about the social determinants of health and that ONC is pushing towards including them. I agree with what Ann said, that I think that just by de novo, I think the electronic health record could widen disparities potentially, and figuring out how to capture this data, but also how to use it mostly for the best for the community, I think is really important. My question was related to, does ONC do anything related to vendors and encouraging them to communicate across types of electronic health records? So having one electronic health record, I mean, sort of moving toward this big data interoperability.
So there are certain meaningful use requirements that are starting to try to get at interoperability, but I think that that's been the thing that's lagged behind in the whole process, right? I'm not up on all of the certification standards and whether some of those are starting to require or to make voluntary some of the kind of like the social determinants of health could be required to be part of the certified electronic health record, but not necessarily be required for payment purposes. So that's something we could definitely look into to see kind of how far they've gotten on the certification side of interoperability, but on the meaningful use side, they haven't got very far at all in requiring systems to actually talk to each other. I mean, they're starting to require you to test it out, but they're not actually requiring massive movement toward interoperability yet. That's the ultimate goal, right? But we're still a ways behind.
So in the CMS proposed meaningful use stage 3 rules, is there any representation of these data?
No.
No.
Okay. Yeah, we haven't seen that yet. And as I said, I think we'll see other iterations of meaningful use stages in the future because we can't have this exact stage for all time, right? But unlike the, say, inpatient payment or outpatient payment world where, like, every year there's a proposed rule and a final rule, every April a proposed rule and inpatient payments comes out, every August the final rule comes out. We don't have that in the meaningful use world, and so it's hard to know what to expect in terms of when the next iteration will come. We didn't know that stage 3 was going to come this year. We've had signals that stage 3 was going to rise since like last spring, but it took a while to get out. And so, I mean, I'd anticipate like maybe in 2 years we'll see another stage, call it stage 4, I think they want to get rid of the stages altogether, just call it meaningful use. And so that's where the opportunity lies to try to influence what might be in that stage.
I have a couple of comments from our online participants. Comment 1 states that Meaningful Use 2 in the 2014 edition proposed to expand demographic data collection requirements to include race and ethnic subgroups, but it wasn't included in the final rule. And those expanded standards were also recommended in the IOM report. Do you have any comments on that?
I don't have any additional information.
Okay. And then the next comment, the next comment was speaking about the vendor community. So this person said that there will likely be pushback from the vendor community on the complexity and the time or money that's involved in incorporating this data into EHR or HIT products.
I think that's right. I mean, there's generally pushback from the vendor community when we're asked to add anything to the electronic health record. So, I mean, that comment doesn't surprise me. I think it's probably spot on. But two sides can push in any game, right? So, yeah, I think it's one of those things that requires an ongoing dialogue from communities like this to speak with the government, to make sure that they know that there are voices urging them in a different direction. Anybody else? Great. Well, thank you so much for having me here this morning. I appreciate it.